So now we will move into the question and answer session. So Charlie and Val, could I ask you to introduce yourselves, starting with Charlie?
Hi, nice to see everybody today. My name is Charlie Gourley. I'm Professor of Medical Oncology at the University of Edinburgh. I've got a lab group who does research into the genes that are particularly important in lots of types of ovarian cancer. And I've also got a clinical trials group who perform clinical trials into these ovarian cancers. And I'll just also apologise for the fact I'm wearing these blue scrubs. I'm in the coronavirus ward today, so that's the reason for that.
Thank you, Val.
Hi, I'm Val Lang. I'm one of the nurse advisors at Target Ovarian Cancer. Quite a few of you I know and have chatted to on the phone, so nice to put faces to some of you. And I'll be just doing the questions along with Charlie today, and adding the bits that the Target Ovarian Cancer and the Spotlight can help you with.
So to kick off, can I just ask you, Charlie and Val, are there any questions or topics that you really hope people will ask you about today?
Well, I guess hopefully people will be interested in the new things that are coming along. You know, there's lots of exciting new research, and there are many exciting new developments, and so it's easy to feel down about everything when you've got a cancer diagnosis, but I think there's certainly lots of hope in ovarian cancer, so hopefully we can discuss some of that.
And Val?
Well, my role is always about support, so you know, anything really, questions about how we can help, how we can support, how we can help people deal with the now, move forward, and all those kind of things really.
Great, thank you. Okay, so I think we're going to kick off with some questions that have been sent in advance, and we've had a couple about the coronavirus COVID situation and how this might be affecting people's treatment, so we'll start with those. So the first question was, how worried should we be if we're facing an operation or treatment such as chemotherapy while we're in the pandemic?
Well, you know, everything's got to be put in perspective. And of course, people worry about going into hospital for anything during the pandemic because there's a risk of picking up coronavirus in hospitals. I would say that I think hospitals have become very good now at having what we call green areas, which are clean areas, and red areas where there are patients who may have coronavirus. And everything's got to be weighed up. And obviously cancer diagnosis is a serious diagnosis. And in my opinion, in most cases, the necessity to go into hospital when you've been newly diagnosed with ovarian cancer will far outweigh any risk of coronavirus. I mean, in terms of the actual impact that having a cancer diagnosis makes on either your chance of getting coronavirus or your chance of having an adverse outcome with coronavirus, it's really uncertain. So there have been a lot of assumptions have been made that people with cancer might do worse or people on chemotherapy might do worse. Well, actually, there was a paper that's come out in the last week that says we can't really say that yet. A lot of the papers that have been published so far, when you interpret them properly, they don't really show that. So I think there's a lot of uncertainty. I think it's fair to assume you'd probably rather not be on chemotherapy when there's a coronavirus epidemic. But if you need the chemotherapy for your cancer, then that's probably the most important thing. And that combined with good shielding is probably the best thing for you as an individual. That would be my take on it, Sam.
Val, did you have anything? Yeah.
Yeah, just that as you said, cancer diagnosis, cancer treatment is always sort of scary and anxiety provoking, and in the midst of a pandemic more so. But the women that I have spoken to and my colleague Rachel has spoken to, once they sort of entered into the treatment, that they say that they feel quite confident quite safe because of the measures that the hospitals are putting into place. So women that were already on chemotherapy have seen a difference with, you know, relatives not being allowed in, waiting in the cars to go in at their time. So, you know, there's a lot being done to keep things as safe as possible, and I think that is quite reassuring, as reassuring as it can be when you're facing treatment in uncertain times.
So one of the things that's been talked about and being put into place at the moment is the COVID-free cancer hubs. So we've had somebody ask who can access those and where are they?
We're in England there, I think most of the cancer alliances, so the groups that join together, have got COVID-free hubs. Who can access them? That's not a selective process in itself. Your case, you know, cases are still discussed on an individual basis by a multidisciplinary team. So and those decisions are made around best treatment for you, safest treatment for you. So if you know, it's considered an operation is the best treatment for you in these circumstances, then it would be a case of you would be treated in one of those COVID-free hubs if there is one available. There isn't a selection process that some people can go to the COVID-free hub and some people don't. That's not how it works.
Right. Charlie, did you have anything to add on that?
Well, I mean, it's slightly different in Scotland. We have some hospitals where operations are happening where often some of the private hospitals allowed just other operations to happen, and they're meant to be completely COVID-free areas. But in most of the hospitals, we've got what we call green areas, which are COVID-free, and red areas where people who might have COVID are all channeled through until they have 1 or 2 negative tests.
Great, thank you. So we're going to move now into some questions about ovarian cancer treatment generally. So we received a lot of questions in advance about PARP inhibitor drugs and who can access what treatments. So Charlie, would you be able to give us a very brief explanation of what a PARP inhibitor is, and perhaps explain to us why there's a slightly different treatment for different groups, particularly for women with a BRCA mutation?
Yeah, so I mean, PARP inhibitors are really exciting new drugs that have really, you know, revolutionized, I think, how we believe ovarian cancer patients will get on. And the way they work is quite complex because they really target the Achilles heel of some of these ovarian cancers. So some of these ovarian cancers have developed because they're not very good at repairing DNA. And these PARP inhibitors target that weakness, essentially. And patients who've got a BRCA1 or a BRCA2 mutation, they have lost that DNA repairability, so they're particularly susceptible to these PARP inhibitors. But also there are quite a lot of other ovarian cancer patients who don't have a BRCA mutation, who still have that DNA repair deficiency, who would also benefit from PARP inhibitors. And so the way it's worked out is that as the trials have come through, the licenses and the approvals for use in the UK have developed in such a way that some drugs are approved only if patients have a BRCA1 or a BRCA2 mutation, and other drugs are approved regardless of whether patients have got a BRCA1 or a BRCA2 mutation. And it's changing quite quickly. So, for example, in the first line setting, that is, after ladies have had an operation and chemotherapy, then if they've got a BRCA1 or a BRCA2 mutation, they can receive one of these PARP inhibitor drugs for 2 years as a 2-year maintenance. And that has a big impact on delaying the cancer coming back. And then if patients don't have a BRCA mutation, or if they do have a BRCA mutation and they didn't get the PARP inhibitor in the first line, then they can get one after they have chemotherapy for second line, for a second relapse, as long as they're something called platinum sensitive. So we can divide our patients into platinum sensitive or platinum resistant according to how long it was since between their most recent platinum chemotherapy and their cancer coming back. And if it's more than 6 months, they're platinum sensitive. So essentially, most women whose cancer comes back will be potentially eligible for one of these. I guess the exception would be patients whose ovarian cancer is clear cell or mucinous or low-grade serous or low-grade endometrioid. But the most common types, high-grade serous and high-grade endometrioid, they would be eligible for one PARP inhibitor or another.
And we also had a question about whether PARP inhibitors, whether we expect availability to change. So someone's asked, will it soon be possible to go onto a PARP inhibitor for a recurrence after only one previous course of chemo rather than the 2 that are currently offered?
So, yeah, so that interpretation of that question, I interpreted that as meaning that the cancer had come back, but they hadn't had chemotherapy for that recurrence. So they were talking about using the PARP inhibitor as a therapy rather than as a maintenance. So most of the licenses and most of the availability in the UK is as a maintenance therapy. So that means patients had a response to their chemo, and then the PARP inhibitor is given in order to keep the cancer away as long as possible. But this question is asking whether it can be given as a therapy. And the answer is that PARP inhibitors do work as a therapy. And we've done trials of them. And in fact, the first trials they were given as a therapy rather than as a maintenance. And they are effective. Now, at this point in time, you know, they're not meant to be used in that setting, although I believe there has been sort of a bit of guidance suggesting that during the coronavirus situation, it might be possible to prescribe these. And the recent British Gynae Cancer Society guidelines that came out do suggest that as an option. They say that NICE has suggested it's an option. Now, I scoured the NICE website last night to try and find the actual reference to that. I couldn't find it. But anyway, these new British Gynae Cancer Society guidelines say that is possible, and it's certainly something that's been put into guidelines in Scotland. However, what I would say is, my personal opinion is that ladies are better to get the chemotherapy first and then have the PARP inhibitor as a maintenance. And the reason I say that is that we did a study to look at what we call super responders. So those are women who do exceptionally well on PARP inhibitors. And we looked back to see what factors were associated with the highest likelihood of a woman being a super responder, and that means her cancer stays away for a good number of years. And the strongest factor that was associated with being likely to be a super responder was if they'd had a very good response to the chemotherapy they'd had before they got the PARP inhibitor. So I think that there's a good rationale for having chemo before the PARP inhibitor. And if a patient was asking me, and if we had both options, I would say yes, chemo first would be best.
So we've had a question come in from somebody watching on Facebook, which is about chemo. So they've asked roughly how many different chemotherapy drugs are currently available for ovarian cancer?
It's actually not very many, to be honest with you. So, I mean, our standard drugs, first line, are carboplatin and paclitaxel. In the relapse disease setting, we would use carboplatin and a drug called Calyx or pegylated liposomal doxorubicin. Some people might use carboplatin and gemcitabine. So what's that? How many is that? We're kind of 4 or 5. And then, you know, there are other drugs that are less often used. Cisplatin is an older drug that we do still sometimes use, a drug called topotecan. And there's only about, you know, 6 or 7 standard chemotherapy drugs that we would normally use. There are a few that would be used very rarely, like cyclophosphamide. You know, obviously there are other drugs that I wouldn't really call chemotherapy, you know, such as PARP inhibitors, for example, or endocrine agents like tamoxifen or letrozole, or anti-angiogenic agents like bevacizumab. I wouldn't really call those chemotherapy, but obviously there are anti-cancer therapies we use in ovarian cancer.
And with PARP inhibitors, something that we were asked in advance is we know that there are kind of several available for different groups of women now, such as olaparib and niraparib. So we've been asked, is it possible if women have a recurrence for them to choose a specific treatment if they don't want the one offered?
Yeah, that's a good question. So it's all a bit confusing, to be honest, and it depends whether you live in Scotland or England, and it depends, you know, what your individual circumstances are, whether you've got a BRCA mutation or you don't have a BRCA mutation. Generally speaking, the patients with the BRCA mutations are often offered olaparib, certainly in Scotland. In England, in the first line setting, the only drug they could get is olaparib. In second line, that is after the cancers come back, they could get olaparib, niraparib, or rucaparib. So I imagine that in England, they could choose which of those three options they would prefer. Obviously, that would be a discussion with their oncologist. But those drugs are all available in the second line setting. And, you know, it's always a bit controversial comparing drugs. I think their efficacy is pretty comparable. That is the amount of effect they have on the cancer, I think, is very similar, to be honest.
Thank you. We've also got a few questions coming through about niraparib. So we've been asked, what's the latest information about this treatment and how successful has it been so far?
Well, like the other PARP inhibitors, it's been really successful. You know, I mean, they are great drugs for ovarian cancer, high-grade serous or high-grade endometrioid ovarian cancer, I should say. And it's been very successful. The way this drug has been developed is that they've been less interested in looking for the small subgroups of patients that respond best. So they've not really been chasing BRCA1 and BRCA2 subgroups. Instead, they've kind of focused on giving it to everybody with high-grade serous or high-grade endometrioid ovarian cancer. And in patients whose cancers come back, it's been shown very clearly that regardless of whether patients have a BRCA mutation or not, this drug will delay the time until the cancer relapses. And that's in patients whose cancers already come back. And that's when it's given as a maintenance after chemotherapy. However, they've also published a recent trial in the first line setting, which again showed after women have had their operation and their chemotherapy, if this is given as a maintenance, it again delays the time until the cancer comes back again. And that's regardless of whether patients have a BRCA mutation or not. And so, you know, I would say the evidence is that this is a very good drug, no question, and that's first line or relapse.
Thank you. I think this leads us quite nicely into another group of questions that we've had. So, Charlie, we had a lot of questions about your work and what you were up to, and in particular around the drug trametinib. So I was wondering if you could give us a brief explanation of your general research work and how things are going, particularly with trametinib.
Yeah, so my lab group does sequencing of tumors basically, and looks at which genes are switched on and switched off, etc. And we look at all forms of ovarian cancer. So we've just completed a big study of high-grade serous ovarian cancer. We've got a paper currently being reviewed about endometrioid ovarian cancer. And then a lot of the questions that came in were about low-grade serous ovarian cancer, which again, we've been involved with sequencing, but also we've done a very big clinical trial, which was recently presented. It was presented about 6 months ago in Barcelona, and this was the drug trametinib, where patients who had low-grade serous ovarian cancer, which is a rare form of ovarian cancer that affects young women, those patients either got the new drug or got standard of care therapy. And what we showed was that the new drug, the trametinib drug, really halved the rate at which the cancer came back, and it quadrupled the chance of the cancer shrinking. And so those data have been presented, as I say, and they're currently, again, that manuscript is submitted for publication.
Lovely.
So, I mean, I don't know if you want any more specifics around about the metinib thing or just now.
Yeah, so some of the kind of questions that we had were around how people on the trial responded to it, or how people were responding to it. Does the BRCA gene make any difference to how people were responding, and kind of what general developments people should be looking out for?
Yeah, so the BRCA gene isn't usually a problem in low-grade serous ovarian cancer. It's usually not altered in low-grade serous ovarian cancer. And so any BRCA gene alteration wouldn't really affect the chance of responding to this drug trametinib. However, within these low-grade serous cancers, there are other genes which can be mutated. Largely speaking, these are not genes that women have inherited from their mum and dad. Instead, these are genes that become mutated only in the cancer cells. So what we're currently doing is we're currently sequencing all of the samples from the patients who were in the study in order to work out whether mutations in these genes were more likely to make the patients respond to this trametinib drug. We believe that mutations in these genes will predict the response to the trametinib, but we need to show it. And so that sequencing is going on just now.
Great. And we've had quite a few questions as well about if there are any other developments to look out for in terms of low-grade serous.
Yeah, so the slight problem with low-grade serous ovarian cancer is that, you know, it hasn't had the same amount of investment as high-grade serous ovarian cancer in terms of research. Now, people are kind of waking up to it, and there are you know, quite a lot of groups now getting together, and there are some kind of global initiatives to try and sort this out. So at this point in time, we don't have our next kind of UK study set up yet. There is an interesting signal from a phase 1 study that was done at the Royal Marsden, and this was published just in the last week or so, about a drug called FAK inhibitor, used together with a MEK inhibitor. Now, trametinib is a MEK inhibitor. So that's quite interesting. The funding that my lab's been given from Target Ovarian Cancer is to look at low-grade serous ovarian cancers in the lab and expose them to thousands of different drugs. So we've got this thing called high throughput drug screening, where we're growing the cancer cells in the lab and we literally put thousands of different drugs on top of those cells in order to try and work out which drugs kill them best. And then once we can identify which drugs work best on these low-grade ovarian cancer cells in the lab, some of those drugs may already be available, and we can then put them straight into trials. Some of those drugs may need further development before they can go into trials. But the reason why Target Ovarian Cancer gave us this money is to allow us to try and work out what sort of drugs work best in these patients, and also to link it in with the genetics of the tumour. And hopefully this can lead to our next generation of low-grade serous ovarian cancer studies.
And someone's asked when that program that Target Ovarian Cancer funded with you, when that's starting, and that has already started.
Yeah, so that's already started. So some of it's to do with sequencing, which luckily we were able to get some of that done before the kind of lockdown. So some of that sequence data is available and is being analysed by our bioinformaticians. They're sitting in their houses at home doing that, but that's fine. And then obviously as soon as we get back, which we believe or we hope will be next month, then the rest of that program will continue, but it's already started.
Thank you. We touched a little bit on trametinib before, and we've had a few people who are interested in hearing about when it might be accessible in the UK and whether it will be accessible across the UK.
So yeah, so I would say that anybody who has low-grade serous ovarian cancer that's come back should try and get it one way or another. The ways that we have accessed it for our patients is we have put in these individual funding requests. That's what we did initially. And we were lucky enough to get some of them approved. Now, I know that different health boards or different health trusts look at these things differently. And just because one health trust approves it, it doesn't mean another one will. But that's one potential avenue. Another potential avenue is that the drug company that makes trametinib, Novartis, has kindly agreed to open up a patient access scheme, which will allow access to the drug. Now, that's great. I think it will be limited to a certain number of women per year, which is obviously a difficult thing to deal with, but I think they have certain limitations regarding how big a program they can run for nothing. We're currently in discussion with them about trying to get a license for trametinib in low-grade serous ovarian cancer based on the trial data that we produced. That would be the best solution, because if they decide as a company that they would go and get a license for this drug, then it means that the drug could then be put through NICE and potentially put on the formularies and made available to anybody who needs it. So for me, that would be the best solution. But that requires the drug company to feel that this is a worthwhile thing to do. So that is that's something we're in discussion with them about.
Thank you. And we've also had a few questions about side effects and trametinib. So someone's asked about what the main side effects were and were there any serious ones and was it possible to mitigate? And then we've also had some questions about how long side effects might start after you started it. I wondered if you could give us some information on that.
Yeah, so the commonest side effect is rash, which happens quite often. We give patients antibiotics to take, which helps the rash, but that's certainly the commonest. Other quite common side effects are nausea, fatigue, diarrhea, and high blood pressure. So the high blood pressure we can deal with for the most part, and the nausea and the fatigue and the diarrhea are usually low grade. So usually speaking, they're not too severe. If they are severe, then we cut the dose of the trametinib. In terms of severe side effects, then they come really into two groups. One group is that there are eye side effects. So the retina can be affected in maybe about 2% of patients. So we get patients' eyes checked up if they have any symptoms, essentially, and stop the drug. And then the other main group of potentially serious side effects are that the drug can affect how strongly the heart contracts. So we monitor the function of the heart while patients are on this drug. And we were quite worried about this, but I have to say that during the trial, there were some women whose strength of their heart contraction diminished. But then when we stopped the drug, the heart got stronger again. And in some cases, we were able to restart it. So we were just learning our way really with that. But those are the two main groups of severe side effects.
Great, thank you. So I think we're going to talk a little bit now about some questions that we've had about management options for rare types of ovarian cancer. So somebody's asked us, is there any new guidance for oncologists about the management options for rare types of ovarian cancer in light of any new research?
So yeah, so actually it can be quite difficult for oncologists to keep up with everything that's going on, and particularly in rare forms of ovarian cancer where they might actually not see very many cases. They might see 1 or 2 cases per year, so quite difficult to keep on top of it. But there are now kind of international collaborations that put together guidelines by international experts. And the most recent iteration of those is something called ESGO, Rare Tumour Guidelines, European Society of Gynae-Oncology. And they've cut these into 2 batches, but the first batch were presented just at the end of last year and are going to be made available in an app so that it can be accessed electronically. And I was involved in writing the low-grade serous ones, but there are also guidelines for clear cell ovarian cancer, mucinous ovarian cancer, and actually a lot of other rare gynecological cancers. And so those guidelines are out there. And so any oncologist who gets a rare cancer landing in front of them, either in the clinic or the multidisciplinary team meeting, can access these on their phone, and that could be pretty useful.
So we're going to move now for a few minutes to talk about genetics. Somebody's asked, my grandmother had ovarian cancer, but we both tested negative for BRCA1 and 2. Should we explore the possibility of a different gene? Is there any indication that this could be passed down, or could it just be coincidental?
So that depends on what sort of ovarian cancer it was. So high-grade serous ovarian cancer, for example, there can be other genes that are hereditary that can cause it. So there's a gene called RAD51C, RAD51D, there are a few others. And in fact, some centres around the country have started sequencing some of these other genes routinely. Certainly in Scotland, we've been sequencing RAD51C and RAD51D in patients who are BRCA1 or BRCA2 normal. We've been sequencing those for about 10 years. We've now got a panel of about 8 or 9 genes that we routinely sequence. And I think it's similar in some of the places in England. So you may find that some of these genes may have been sequenced. Now, if it's a different form of ovarian cancer, like, for example, low-grade serous ovarian cancer or clear cell ovarian cancer, then those sorts of ovarian cancer are not traditionally felt to be associated with a gene defect that you can inherit from your mother or father. However, I would say that in our most recent study, we think we've identified a gene that could very occasionally cause hereditary low-grade serous ovarian cancer. So we are just trying to validate that work just now. But that would be a very rare event.
Thank you. We've got some questions, more questions coming in about chemo, which I thought we could cover. So we've been asked, I have low-grade serous carcinoma. I understand that some doctors offer chemo and some don't. What would you recommend?
So this is a big bone of contention. So previously, when we thought all ovarian cancers were the same, of course, all our low-grade serous patients got chemotherapy. And all the trials that say whether to give chemotherapy or not just put all ovarian cancers into the same bag, really. And that, we now know that's wrong, okay? And so actually, when we look at the chance of a low-grade serous ovarian cancer responding to chemotherapy, it's actually pretty low. And so for that reason, I don't always offer it to my patients. Now, I have to point out there is disagreement around the world about this, about whether they should get chemotherapy or not. And occasionally I will offer my patients chemo with low-grade serous based on individual circumstances. But there was a study that was published that suggests that giving hormone therapy, drugs such as letrozole, is probably a more effective treatment. And the big question is whether you should give chemotherapy and the letrozole in newly diagnosed patients, or whether you should just give the letrozole. And we don't really know the answer to that for sure. All we can do is look back at some of these, what are called retrospective studies, which looked at how patients got on, and that's not high quality data. But there is a study starting in the US, which is giving half the patients chemo plus this letrozole drug, and the other half just the letrozole. And what that study is aiming to show is that you don't really need the chemo. Until we get the result from that, it'll be based on the discussion between the patient and the oncologist. Normally speaking, I kind of veer away from it, to be honest. The main exception to that would be if the patient qualified to get chemotherapy plus bevacizumab or Avastin. And that's because bevacizumab stroke Avastin is an effective therapy in low-grade serous ovarian cancer. And in the UK, there are limitations as to when you can access that for the patient and get it paid for. And so sometimes there's a little bit of what we would call gamesmanship round about that. So in order to make sure we can access all the main effective therapies for the patient, then sometimes they might get the chemotherapy as part of a package that includes Avastin.
Thank you. Another chemo question. Somebody's asked, can you do PARP inhibitors alongside chemo? Or, sorry, I'm just reading this off. So, or if chemo is stopped because of coronavirus, can it be reintroduced at a later date alongside a PARP inhibitor?
So it's quite difficult to give PARP inhibitors with chemotherapy. And the reason for that is that they have what we call overlapping toxicities. And so for the most part, the PARP inhibitors compound some of the main side effects of the chemo, in particular, the impact on the bone marrow. So chemotherapy causes the white cell count to go low, causes the platelets in the blood to go low, and PARP inhibitors also cause that. And so when you give the two together, in order to do that, for most of the PARP inhibitors, it compromises the dose of chemotherapy that you can give. So you have to give less chemo because otherwise the patient can't tolerate it. There is one exception, and that is that there's a PARP inhibitor called veliparib, which can be given with chemotherapy, but it's not licensed or reimbursed in this country. There was a recent publication presented about 6 months ago that showed that it can be given with chemo. But the benefit of that is yet to be shown. It seems that most of the benefit is from giving it after chemo. And so I would say the PARP inhibitors we have available to us right now, we can't really give them at the same time as chemo.
Okay, we're going to move into talking a little bit about recurrent ovarian cancer now. So somebody's asked, how likely is it that ovarian cancer will come back?
So that it's impossible to give one number that covers everybody, because the risk of the cancer coming back is really dependent on the individual circumstances. It depends on the stage of the tumour, what sort of ovarian cancer it is. It depends whether the patient had an operation and how much was possible to be cut out. And it depends a bit on the genetics of the cancer as well. So it's impossible really to give one number that covers everybody. I mean, you know, for an early stage, low-grade endometrioid cancer, the chance of it coming back might only be 5%. And, you know, and for a stage 4 ovarian cancer, obviously it's a lot higher than that. You know, it may be 85% or more. What I would say, in case anybody's sitting there and is thinking to themselves, that's me and I'm not in a good situation, I would say that some of our new cancer therapies that have just become available to us may change that. And so these PARP inhibitors have shown they can delay the time till the cancer comes back. We haven't yet seen whether they cure more people, but we're really hopeful that they do. We should know that in the next year or two. And so I'm really hopeful that you know, this discussion that we're having now will be able to say that because of the introduction of PARP inhibitors, many less patients with advanced stage ovarian cancer will relapse. That's what we're hoping for.
Well,
did you have anything to add on that?
Not really, just the usual warning about being bogged down in statistics. You know, sometimes it can be really scary, but as Charlie's saying, you know, it's an ever-moving picture. So to sort of pinpoint something and let that sort of take over, it is, you know, that might not be how it is in the future. So I think, you know, keep statistics in perspective really, and you don't know which one you are. So there's almost irrelevant to you unless you do know that.
Thank you. So something that we get asked about a lot is the use of CA-125 testing to monitor recurrence, so if ovarian cancer is coming back. And we've been asked, how reliable are these tests? to detect a recurrence? And what would you expect to do if someone's CA125 level rises but they don't have any symptoms?
So in a patient who has had ovarian cancer, if at initial diagnosis their CA125 was high, then the CA125 test can be a useful indicator. Now, of course, there are times when the CA125 goes up and it's not due to the cancer, but it can be a useful indicator. So in my practice, well, I offer the patients the option of whether they want CA125 testing or not. It's up to them, because it can induce a lot of anxiety. You can get into a situation where the only thing they care about when they come to the clinic is what that number is, and that's a little bit difficult. But if they are having it done, and I think overall my preference would be to have it done, then if it goes up, I ask them if they've got any symptoms, and I usually arrange a scan to see if there's any evidence of anything having changed on the scan.
Thank you. And we've had some questions about side effects as well. So someone's asked, chemo left me with neuropathy in my hands and feet. My drugs were adjusted when it started to impact my hands. I feel that things are gradually returning, but my toes are still numb and freezing. Is there anything I can do to help that?
So, well, that's a difficult one. I mean, it's quite difficult to treat that chemotherapy-induced peripheral neuropathy, and I don't think there's anything that really helps particularly well. Sometimes, if the neuropathy has a pain component, then sometimes using some anti-epileptic drugs can help. So, you know, a drug like gabapentin, for example. You know, in terms of numbness, it's very difficult. You know, you can try things like, you know, feet massages, but there's nothing that's been shown to be really effective. We actually have a professor of palliative care here in Edinburgh who is doing a lot of research into this, and she's doing trials of menthol, and she does have anecdotal cases that have got better, but at this point in time it's just anecdotal. So if you do have anybody locally who's doing trials into peripheral neuropathy, then I would definitely recommend that, because as an oncologist, it's a really frustrating thing to deal with. We don't have anything that's really good to deal with that, to be quite frank. This lady's also tried using TENS machines, you know, like they use in pregnancy, giving electrical stimulation to try and help. But, you know, a lot of that is very much still in the research space, and a very difficult thing. I don't know if Val has anything to add to that.
Nothing to add about trying to help, you know, combat the numbness and things, but just general really about, while your extremities are numb and you're not feeling them, just about being careful and making sure that you look after your feet. If your toes are numb, your feet are numb, you know, always make sure you've got shoes on, because you don't always know if you're stepping on something, damaging your feet, inspecting your feet. And just being careful, things like, you know, don't run about and put your foot in first if you've got a numb foot, always check with your hands, and, you know, simple but sometimes things that we forget. But look after your feet so that, you know, hopefully when some sensation starts to come back, you're still in good shape.
Thanks. We've got a question about topical estrogen. So they've asked, is it safe to use topical estrogen? And the person who asked is taking anastrozole, but I guess this is something that's probably of interest to people on other treatments as well.
Yeah, so it's a bit similar to the whole question about hormone replacement therapy. So it depends on what sort of ovarian cancer it is. And if the patient has a cancer that might be sensitive to estrogen, and the way we assess that in our practice in Edinburgh is to check whether there were estrogen receptors on the primary tumour. If that's the case, then I would definitely not recommend HRT. And of course, the whole idea about topical estrogen is the amount of estrogen that is absorbed is meant to be very small. So I would still have some slight concerns, to be honest with you. So it would depend whether it was a tumour that was potentially estrogen responsive or not. If it was a clear cell ovarian cancer or a mucinous ovarian cancer, I'd probably be okay with it. But the fact that the patient's on an anastrozole suggests that it's not one of those, and I would probably be slightly nervous about it, to be quite honest.
We've had a question about support for younger women. So we've been asked, how can Target Ovarian Cancer support younger women who are going through the severe effects of surgical menopause? And also a question which is just, is there any new general advice for young women with ovarian cancer?
So, so I think the surgical menopause thing is massive. It's such a big problem. And, you know, there is some debate about hormone replacement therapy. I've seen some publications suggesting it's a good idea. Generally speaking, I don't think it's a good idea. I think we need to learn more about which patients it's okay for and which it's not okay for, because I think there are patients out there in whom it's definitely not okay. And the reason I say that is we give drugs to block estrogen receptors. So why would we put estrogen back in? That doesn't make sense. So, but in terms of the support thing, I think it's absolutely crucial. And so what we did here in Edinburgh is we wrote some guidelines along with our menopause clinic colleagues. And so we wrote these guidelines together, and we've got a direct route to them with patients like this. And they provide all the expert guidance on symptom control. And, you know, I hope I'm not, you know, I can't really speak for Target Ovarian Cancer, but I don't think it would be a bad idea if they wanted to, you know, make some guidelines, you know, along those lines, because it's a major problem, and I think peer support would be really, really important and helpful. You know, access to experts, and I don't regard myself as an expert in managing menopausal symptoms. That's why we send these ladies to our local experts in this area, so that even if we can't give them hormone replacement, we can give them the best possible symptomatic management of those circumstances. Don't know if Val wants to add anything about that.
I think, you know, give us a call actually, because it is a problem. You know, you get smacked with an ovarian cancer diagnosis, then straight into a menopause, which is difficult for all women, but for younger women particularly, they don't have friends that they can chat to about it because nobody else is in that position. So give us a ring, we can talk about it with you, and then to point you in the right direction, discuss, you know, what alternatives may be available and who to seek support from. And there's I think the DAISY network, and there are networks and groups set up for women with not just surgically induced menopause, but women who have a naturally early menopause. So there is, you know, there are groups, there is support. But yeah, please do ring, and we can talk through that with you.
Thank you. So we've had a couple of really interesting questions. So there are lots of books out there about how to stop cancer coming back, including diet, relaxation, exercise, etc. Do you subscribe to any of these? And is there scientific evidence in any of these works?
So this is tricky. So I guess most of the management that we suggest in our clinics is based around research, positive research. And the problem with some of these books is, although some of them, you know, I think dietary advice in general is good, and you know, and although they address some very important questions, they maybe don't always do it in a scientifically robust fashion, and they're not subject to something we call peer review, which is what all scientific papers are subject to. So when I want to publish a trial and say, well, this is the way we think we should now treat ovarian cancer because of these results, then experts from around the world will look at my paper and they'll say what's right with it, what's wrong with it, and decide whether it's robust enough for publication or not. These books aren't subject to those sort of scientific scrutinies. So, you know, I have to say, so in terms of, you know, diet and other strategies that come through in these, I don't think there's anything that's strong enough that at this point in time I would advocate it. Now, that doesn't mean that it's not okay for people to read it, get some strength from it, think this might improve my life if I do this, and try it. That's fine. But you know, as I say, I go in the scientific papers is really where my advice would come from.
Val, anything to add on that?
Not really, just sort of general, you know, good diet, try be as healthy as you can, take some exercise. I think that is the best way forward, really. A sort of general look after yourself and you know, keep well.
Fabulous. So I think we're going to have to finish up now. But Charlie and Val, could you just maybe share with us one thing that you'd like women to take away from this session with them?
Yeah, really, from my perspective, you know, there are a lot of great things happening in terms of a lot of exciting developments. I really mean that. And so I don't think, you know, I would feel quite positive about the current environment. And if you're worried about your situation, speak to your oncologist. And if you think you need some different avenue, ask them what research is going on, and you know, feel positive about the future. You know, that's what I would suggest.
Val?
For me, of course, you know what Charlie said about things going forward, but from us, just for women to know that there is support available and that you can come forward for that, not just you, but your relatives as well. And, you know, we are there. It doesn't have to be a technical question or you want to talk about anything in particular. Sometimes women just enjoy ringing for a chat just to speak to somebody removed from the situation. So please, yes, just know that we're there and pick up the phone and ring me or Rachel. We'd be delighted to hear from you always.
Thank you. So thank you everyone so much for joining us. We hope you enjoyed it and we hope you found it helpful. I'm conscious that we had tons of questions coming through and ones that were sent in advance that we didn't have time to get through today. And some of them were quite specific. So we'll be sending you out a feedback form either today or before the end of the week. And on that form, you'll have the opportunity to let us know if you'd still like us to answer your question one-to-one, so either through a call on the support line or by email. So you will have a chance to get your questions answered if you want us to do so. And please do send your feedback form to us. We'd love to hear what you thought, particularly given that this was our first session. We know that we can always make improvements and make it go smoothly. So as Val mentioned, our support line is always available if you want to talk about anything, just to have a chat. So you can call us on 020-7923-5475, or you can go to targetovariancancer.org.uk/support and there's information there. We also have some other digital events coming up that you might be interested in joining. Our next session is about living with fatigue, and that's on the 4th of June. And we also have a regular free yoga and relaxation session for women with ovarian cancer every Wednesday afternoon, and you can find more information about that on the website. So thank you for joining us, and I hope you have a lovely rest of the day.